Top Med Talk.
Nick Majerison here, welcome to Top Med Talk. This piece is in 4 parts and this is the third of them. It's called the Perioperative Cognition Workshop and it took place at the Australian and New Zealand College of Anaesthetists earlier this year. The other parts to this piece are available on topmedtalk.com if you check in the show notes for this podcast.
We do have an infographic. So this is from the cognitive care standards from the Australian Commission on Safety and Quality in Healthcare. It should be part of all hospitals now and will become part of guidelines for the prevention of delirium. So I just wanted to highlight the infographic and what it tells us is the seriousness of delirium in acute care hospitals. So delirium obviously affects not just surgical patients, it affects a lot of medical patients and ICU patients. What we're interested in is the post-operative delirium. And you can see that the risk of death is increased and certainly something we have found really interesting in our patients is that for research when we're identifying delirium, many patients are discharged home with delirium, with hypoactive delirium. This is a real concern from the point of view of whether they're going to comply with their post-operative instructions. Patients with delirium are 2 times more likely to end up in residential care or institutionalised. They're, as David said, more likely to have dementia. And importantly, there's certainly some evidence that about 30 to 40% of delirium is preventable if we are able to identify patients at risk preoperatively and implement strategies. So the impact of, David's talked about the impact of delirium and I've just covered the impact through that lovely cognitive care infographic. What about for neurocognitive disorder? Well, the impact of neurocognitive disorder is also impacts on mortality. So at 1 year and at 7.5 years, an episode of POCD or neurocognitive disorder at 3 months or 12 months increases the risk of mortality. Patients have a delayed discharge, so their length of stay is increased. Their return to work is decreased at 10 years. They have a decreased quality of life. What we don't know yet is whether or not those patients are at an increased risk of mild cognitive impairment or dementia. There is some evidence in animals that anaesthesia is associated with Alzheimer's disease pathology. At the moment, we don't have answers to those questions. So we do need to know what's happening in the longer term with these patients, and our revised nomenclature is going to help us because we'll actually have the right diagnoses, the right criteria, and be able to talk in the right language about what's happening in the longer term. So this is some work by Jacob Steinmetz and the ISPOD group. So the ISPOD group were one of the very first groups looking at post-operative cognitive dysfunction. It was an international study. This is just the data from the Denmark part of the study in the long term. And what you can see is that mortality is increased in those patients who had an episode of cognitive dysfunction at 3 months. And in fact, patients are more likely to leave their workforce if they had POCD at 1 week.
And the x-axis on the left is up to 14 years and on the right is up to 8 years. So, this is significant long-term impact. Long-term
implications, absolutely. Now, this is looking at delirium outcomes and cognition in the long term. So what you can see, this is the work on the left-hand side is work by Sharon Inouye, who is really the delirium guru, her and Ed Marcantonio. What you can see there is that patients who had an episode of delirium, so that's the blue 95% confidence intervals covering there, had much more likely to have a decline in cognition at 3 years post-operatively. So interestingly, both groups, whether they had delirium or not, had this little decline in the early post-operative time whilst they're recovering, a bit of a, what's the word I'm looking for, overshoot when they're recovering, and then at 3 years post-operatively, patients with an episode of delirium had a much greater decline in cognition. This is baseline standardised and this is baseline actual. So you can see the patients with delirium also started with a slightly lower cognitive index at baseline. and those were non-cardiac surgery patients. In cardiac surgery patients, some work by Jane Szynski, can't say her name, and look, we're seeing exactly the same thing. A bit of a decline early post-operatively, and then the patients without delirium go back to their baseline state. Patients who have an episode of delirium don't go back to the same level. And in fact, patients who have a much more severe, so they're having a delirium for 3 or more days, actually take a lot longer to recover and don't get back to the same as their baseline level. So one of the things that we wanted to talk about today is identifying risk factors for neurocognitive disorder, including post-operative cognitive dysfunction or DNCR and post-operative delirium. So interestingly, what we see is that for delayed neurocognitive recovery or post-operative cognitive dysfunction, it's the same. The risk factors are the same as for mild cognitive impairment and dementia in the community: increasing age, lower education, and pre-existing cognitive impairment. And David will talk a bit more about preoperative cognitive impairment and how prevalent that is in patients presenting for surgery over the age of 65. For POD, so post-operative delirium is a little bit different. So, in fact, the same risk factors, increasing age and cognitive impairment, are important. But as you can see, there's a long list of things that contribute to a patient whether or not they're likely to get an episode of post-operative delirium. So those things, some of them are preventable, obviously. The drugs, the polypharmacy, there are things we can do about that. If we identify patients at risk, we can manage them differently in their perioperative period, making sure they're oriented post-operatively, having a family member there to help them do that, making sure they've got their glasses, making sure they've got their hearing aids. You can imagine how disturbing it would be to be in an environment where you can't see properly and you can't hear and you've just been moved from one place to the other. So one of the things we wanted to do today, even with a large group, we're going to teach some screening tools. So what we would like you to come out with at the end of this is to understand simple screening tools for cognition and delirium, what the difference between a screening tool and a proper neuropsychological assessment is, and learn the basics of how to score those screening tools and interpret the results. Hand over to David.
So I guess it's important to understand the difference between screening and diagnostic tools as well. And it's a bit like what we do with cardiac assessments and other clinical assessments. Screening tools need to be used on a relevant population. So if you apply chest X-ray across everyone, you'll find lung lesions which are not relevant, and in investigating those, you'll cause complications. Same way, if you apply screening tools across the population, you'll get a false positive rate, which is unhelpful. So you need to get the best discrimination. You need to be selective in who you apply screening tests for. So for cognitive impairment screening tools, for instance, you would be picking older patients or patients in whom you had some suspicion of memory complaint. Screening tools aren't diagnosis. They don't give you the diagnosis that this patient's got dementia or mild cognitive impairment or whatever. They're an aid to further referral, but they're ideally easy to administer, they're ideally inexpensive and not too time-consuming, and a really good feature of a good screening tool is a high negative predictive value. So what we've got here, I've got the example here of the bowel cancer screening program. So any of you who are over 50 will have got a box in the mail, and you've got to put your stool sample in that box and post it off. And why is that being done? Well, first of all, they've targeted the higher risk group, okay, so over 50-year-old. Secondly, this test for fecal blood is now very sensitive. So if there's no blood there, it's likely to be correct that there is no blood there and that you probably don't have at least a developed bowel cancer. So it's a good screening test because it's got a high negative predictive value. If it's normal, you're unlikely to have the disease. However, if it's positive, you go and meet your smiling gastroenterologist and they will do a colonoscopy, and when they do the colonoscopy, they'll have an index of suspicion about a lesion, and if they think it's suspicious enough, they'll biopsy it, and the histology will come back. So that's, again, raising that level of concern and clarity about the diagnosis. That biopsy itself may not be the final proof, but it usually is enough to lead to the definitive surgery where you might have your lap hemicolectomy, for instance, and then you will still have you'll have a definitive histology to determine whether the lesion has been completely excised and the lymph nodes are clear and so forth. So, the screening test is up here. This is another level of screening, diagnostic screening if you like, but much more sophisticated. So be cautious with false positives. Don't say to a patient immediately that you've got dementia. Sorry, mate, because you didn't do too well on your MMSE. But you would use that result either acutely to guide your care and raise your level of concern for the patient, particularly for other indicators such as a memory complaint, and it should lead to further and more specific testing if there are concerns. So, in practice, for us, the routine clinical interview might pick up someone who's already got a diagnosis. They've been to a memory clinic, their GP's had them assessed, and they've got a diagnosis. So they're already at that level. And then there are the risk factors which I've listed there, which obviously include a number of factors which you may or may not be able to get. Usually we don't have their genotype. If you think there's a cognitive risk, then you can go on and ask, so the older patient, what we talked about, you ask about memory problems. Have you had any memory problems? And that's, as we're saying, is a very useful clinical screening test, just to get an idea of where the patient thinks they sit. Assessing their level of education is an estimate of their cognitive reserve, which is their capacity to cope with an insult. In the same way, level of exercise tolerance is an example of your physical reserve. And really importantly, if you do have information from a partner or other informants, a neighbour who lives with them at work, helps them a lot, or their own GP, that informant information is what is used particularly by geriatricians, but also even in the screening tests where you're sitting down with the patient and you've got their partner with them and their partner's constantly correcting them because they're telling you pork pies. That is helpful information. You know that there's something going on there apart from a relationship difficulty. If they were going to have a formal psychogeriatric assessment for MCI and dementia, it's quite a big deal. It takes a couple of hours. It requires filling out of questionnaires. It requires both a objective but also a gestalt assessment by the geriatrician. And so it is not something that we would be doing. This is about identifying high-risk patients. So if you have someone, you would then refer them on. But if you have a memory concern, you may be able to target their care. And one of the things which really pricks up is if they've had delirium before, one, it puts them at much higher risk for subsequent delirium, but also they're usually very worried about it, as are their family. And that's where we would be, flag that as a very significant predictor of high risk for a subsequent event. So what we need are quick, easy to administer, reliable screening tools for cognitive screening and delirium screening. And I'll hand back to Liz to talk about the mini-cog.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.